Thank you, Julie, for the warm introduction, and thank you all for giving me the opportunity to be here with you this afternoon. One of the great things about being an anesthesiologist is you get to disappoint surgeons every single day of your life. And I like very vividly remember the first time I disappointed a surgeon at Duke. And this was the first day of my internship. And that surgeon was, I think, disappointed with me because I was an anesthesiologist and because I was on her service. And I spent the next 30 days trying to show her that she shouldn't be disappointed, just like I hope to spend the next 15 minutes or so showing y'all that you shouldn't be disappointed with me being here. I have not seen that surgeon since my intern year until today. It turns out it's Dr. Peterson, who I have the honor of sharing the podium with this afternoon. So the other great thing about being an anesthesiologist is you have a lot of free time on your hands. And so I came here yesterday and I rented a mountain bike and I went to Tiger Mountain. And I'm not sure how many of y'all live close by or have the opportunity to do this, but it was an absolutely remarkable experience. I managed to get a number of really great shots and almost kill myself in the process, but I did, again, want to thank you all for giving me the opportunity to be here with you. It's been a wonderful couple of days. So I know we've covered a lot of these concepts in detail. I'm going to try, as Dr. Thacker referenced, give you sort of a different perspective on how we've thought about value critically at Duke University Hospital, and hopefully in this presentation drill down to a use case perspective around how we've leveraged concepts of value to help support our enhanced recovery work and grow it and scale it iteratively across the health system to help impact as many patients as we possibly can. So I'm going to give you a brief overview about value in sort of this post-healthcare reform environment that we find ourselves in, talk a little bit about maximizing value in the perioperative space through ERS, draw some conclusions and recommendations for success, and hope that we leave this presentation this afternoon with an idea of how we can operationalize enhanced recovery work, enhanced recovery programs at each one of our institutions, because ultimately I think that's where we'll obtain value. That's where we'll translate some of the concepts that we've developed in the literature over the last 10 to 15 years into practice. So as we know very well, healthcare performance, particularly in the United States, is pretty poor. If you look at how we rank from a high level, we're dead last amongst industrialized countries with regards to population health performance metrics. And the cost of healthcare, obviously, in this country is still rising pretty dramatically if you look at it on a per capita basis. And then if you look at how both patients and providers view their interactions with the healthcare system, they consistently rank it very poorly. And so we have this kind of mixture of really poor population health-based performance metrics, high cost of care delivery, and then poor assessments of how both the providers and the patients feel about their interactions with the system. And that was the concept, or that was kind of the atmosphere that led to the ACA and to Obamacare coming in 2009. And it was essentially charged with, bringing in a system that would lower costs, that would improve the services provided for patients and improve access to care, essentially enriching the overall value to the system. What we think about a lot, and what I thought about at this time as I had the privilege of training under Dr. Thacker, is how can we think about these core concepts of value inside the perioperative space, and ultimately what can we do to start transitioning to a value-based care approach perioperatively? And we've talked a lot about these concepts already this afternoon with regards to this kind of new, more complex value equation. Where we think about quality and services on the numerator and then cost on the denominator. And a lot of the PRO-based work that Dr. Peterson referenced, a lot of the prehabilitation discussion that we've already had really focus a lot on delineating at a granular level exactly what we need to do to help improve this value equation from a clinical standpoint. And what I'm going to focus on in the next 10 minutes or so is a discussion around cost. And I think ultimately what we should think about when we think about costs, and what I've developed, what I've learned over the last couple of years, is a lot of the costs inside the care that we provide inside each one of our systems revolves around variability and around perioperative stress. And so what we did in order to better understand this is we took a really, really deep dive into the finances behind what the costs of care were for each one of our patients that we wanted to enroll into enhanced recovery type work. And this helped us build a frame of reference around where we could focus, where there were opportunities for low-hanging fruit inside our enhanced recovery programs. And this slide really details what the cost of care is at our organization for patients that come in for laparoscopic colorectal procedures. And what you can see is that time in the hospital, time and supplies in the operating room, and medications really are what drives costs in this patient population, at least on their index hospitalization or their index hospital stay. Similarly, if you look at nephrectomy, which was an enhanced recovery program that we rolled out in the last couple of months, we found very similar findings. Time in the hospital, time and supplies in the OR, medications, big components of where the cost drivers were on the inpatient hospitalization. This changes a little bit for different surgeries, obviously, and this is a slide that depicts prostatectomy. And you can see prostatectomy is generally a procedure where we anticipate having a shorter length of stay, and you can see how much that impacts the total cost of care. So supplies in the operating room, time and supplies are actually combined on this slide, but time and supplies in the OR drive, over 75% of the cost for this patient population. So if you think about how can we improve the value equation on an episode basis, you have to focus your initiative in a place where you think you can get that impact. And for this patient population, it's definitely in the operating room. And so when we thought about this from a colorectal perspective, we thought okay, where can we focus on this? How can we provide value? How can we prove this value to the health system in a way that is digestible so that we can leverage this as an early win to scale the initiative and again, ultimately improve patients' lives outside of just colorectal surgery. And the initial analysis that we did, like Dr. Peterson, like others that presented today, we found about a $2,000 decrease in our total cost of care when we provided a comprehensive enhanced recovery program for this patient population. And then we took this data to sort of a more robust analysis over the course of last year where we analyzed more patients and we tried to determine what specific aspects of the enhanced recovery program were most impactful. And similar to the data that we've seen previously this afternoon, in the end we found that focusing on reducing infection, early mobilization, and optimization of perioperative volume resuscitation guidelines were kind of where our bread and butter were. This is a slide that shows that if you looked at our enhanced recovery program patients versus matched controls at Duke University Hospital, so our surgeons that were doing enhanced recovery work versus those that weren't, in the same population, we have an average length of stay reduction of about 2.5 days, which is consistent with sort of the high-level data you've seen earlier today across the literature. And then we looked at, and we drilled down in the patient population and found that age and ASA status were both correlated with length of stay, so sicker patients, older patients stay in the hospital longer. What was interesting is that we found that the single thing that was most correlated with a decrease in the patient's average length of stay inside colorectal surgery was standardization of the preoperative education deliverable, which for me was absolutely game-changing. So just identifying to patients what we're going to do during the procedure, and as Dr. Thacker always says, what criteria need to be met for you to leave the hospital. That single digestible comment for those patients was the most impactful thing that we did throughout enhanced recovery work to reduce their length of stay. Similarly, one of the other major things that was discussed earlier was this kind of standardization of normovolemia. And we found that if you stopped IV fluids and then needed to restart them on postoperative day 0, suggesting that the patient was either under-resuscitated in the operating room or struggling with nausea and vomiting immediately postoperatively, that increased the average length of stay in the patient population by 2 days. So again, if you think about value propositions, what you can do in your own enhanced recovery work to help streamline the process, to help provide the biggest bang for your buck with regards to how you roll these initiatives out, focusing on these areas could be a way to get an early win in a way that's pretty cost-effective. And then the other thing that we focused a lot on is metrics. And Dr. Thacker can tell you, we've struggled with this over the course of the last several years in identifying how do we actually measure the success of these initiatives in a way that will be impactful for patients so that we can continue to refine this work, but also be impactful for the health system so that we can communicate the overall value of the enhanced recovery work and then ultimately continue to grow our initiatives. And this is a template that we created through our care redesign work in the last couple of months, where we tried to focus on specific measurables that, again, were impactful, that were in the same language as some of our finance leaders. And when we looked at the granular drill down on this data, we found in this slide where you can see colorectal enhanced recovery work on the top part of the slide, and then proctectomy on the bottom part of the slide. And then we just looked at total costs on an episode basis. We found significant reductions in the cost of care provided during that index hospitalization for all but one of our locations and all but one of our procedures. And then this is a kind of general overview slide that allowed us to communicate the efficacy of what we were doing, again, in a way that, that spoke the language for our health system leadership. The other thing that we've developed, and I think is absolutely critical, and it was brought up earlier, is this concept of auditing. And, from a high level, what you want to do is think critically about sort of how you want to measure the benefit of the initiative, how the health system will measure the benefit of the initiative, but then what process measures you can develop along the way to help make sure that you're moving towards that goal. And this is a slide where we've shown exactly that. And this focuses specifically on our prostatectomy patients, and shows in the upper left-hand corner an ERAS indicator that I'll explain in a moment. In the bottom left-hand corner, a pre-op carb drink. In the upper right-hand corner, just making sure that we have our post-operative education in place. And then in the bottom right-hand corner, our ambulation on post-operative day 1. So the ERAS indicator, as Dr. Thacker referenced earlier, was just this concept that we created inside our informatics infrastructure that clearly elucidated that this patient was, in fact, an enhanced recovery patient. A single identifier that was integrated into our preoperative posting, and then was carried forward across the perioperative environment so that every person that touched that patient's care knew that this was an enhanced recovery patient, and then therefore knew the expectations associated with that. And what that graph in the upper left-hand corner shows is this transition from red to blue when we went live with the initiative. So it really shows that we were effectively communicating to our providers that we were going live with an enhanced recovery program. And then that goes back to that education slide that I showed you earlier. So we know that we're optimizing the most important part of this initiative. Similarly, in the bottom left-hand corner, focus on transitioning carbohydrate drinks, which you could see we did quite well with going live with the initiative. And then in the bottom right-hand corner, this is just kind of a control because we were already mobilizing folks on post-operative day 1, so you can sort of see how impactful going live with the initiative was. And I think at the end of the day, auditing what you do is probably the most critical part of communicating value around the initiative. And then the other piece of this that I'll end on with regards to this specific use case is around getting some kind of comprehensive impact statement from the patients as well as providers. And so we have a very blunt tool that we use. It's age caps. Dr. Thacker will tell you we think it's probably the worst tool we could possibly use, but it's all that we have. We were able to show slight improvements in pain management with going live with the initiative, which was helpful for the health system. A pretty substantial reduction in 30-day readmission rate, which to Dr. Lee's comments earlier, we know that a huge part of this, of the cost of care for this patient population, if you think more broadly than the index hospitalization, revolves around complications. So showing that you can reduce 30-day readmissions is a big process measure for that. And then obviously a reduction in length of stay, which we know is typically associated with one of the more significant costs of care during the index hospitalization. So in conclusion, I think, and I feel pretty strongly that we are in the midst of sort of a paradigm shift inside healthcare where we're moving from a fee-for-service-based model to a value-based model. I think that will happen irrespective of kind of short-term fluctuations that we might see because of changes in DC. I think the sort of writing on the wall is that this is where we're going, and this model will continue to transition over the course of the next 10 to 15 years. I think in order to be successful in that environment, we really need to think comprehensively about multidisciplinary care and about what we can do ultimately to think in terms of the patient journey instead of what our specific roles are inside that patient journey. I think that reducing variability can lead to reduced length of stay, reduced perioperative morbidity, and reduced long-term mortality. We have pretty good data in the literature to show that, and I've seen it anecdotally at Duke over the course of the last 5 years. And then as far as recommendations of success or for success are concerned, with regards to your own enhanced recovery work at each one of your organizations, I think the essential elements will be similar, but the protocols have to be customized to each site. Focus on standardization of practices, focus on improving care processes where they're broken. Those are kind of low-hanging fruit that you can use to optimize value in an efficient way. I think what I've learned from this work is that you have to be focused initially, and if you have to focus on one thing, I think we found patient education, expectation management is probably the biggest thing that you can do. And then with regards to some of the other comments in the other lectures this afternoon, focusing on hypoperfusion, on opioid-related side effects, and infection control measures are also really low clinical hanging fruit for you to optimize the efficacy of the initiative. And Dr. Thacker made a plug about some of the informatics work that I do. I think it's absolutely critical to success to have some kind of QI auditing system in place. You can have something really expensive and complex that works only some of the time, like Duke, or you can have something simple, straightforward, and cheap, but you have to have some kind of auditing process to look at both process outcomes as well as final outcomes for the initiative. And I think, in closing, I think the one thing that I've learned from doing this work on the ground in the trenches over the last couple of years is that, you really don't have to come up with some new innovative concept to get these things done. It's really just taking what we already know and finding ways to integrate it into our practices every day. Thank you again for the time and for the opportunity.